So, madam, we are live now. Shall we start?
Okay.
So, good evening, doctors and all the participants. Shobhana on behalf of Shield Healthcare, welcoming you all in today's session on HELLP with pancreatitis pitfalls in diagnosis and treatment. And our guest speaker is Dr. Shobhana Mohandas, madam. So, before moving into the session, let's have a look on this Shield Connect page. This is basically a knowledge sharing platform of Shield Healthcare. Here you can see different blogs written by many eminent doctors in different topics across India. And these are the past sessions, medical sessions. Already we have conducted in our platform by many eminent doctors in various topics as well. And we have also the awareness section. So different awareness section, you can see that in each and every section, you will find the related topics over there. Apart from that, the most important thing is our key opinion leaders. More than 500 doctors are currently supporting us this knowledge sharing initiative of Shield Healthcare. So I would like to request all the participants, please have a look on this website. It is completely dedicated to the medical science. So now it's time to the session, and it's my honor to introduce Madam. Madam is the Chief Consultant and Panhologist in Sun Medical Center, Thrissur, Kerala. Madam is the President-elect. Madam is the President-elect Indian Menopause Society, Senior Vice President IMA Thrissur, Medicine Vice President IMA DW. And Madam was the first Secretary General Website Committee Chair with Chair IMS, first member FOXy Food and Drug Committee and Endocrinology Committee. Madam was the South Zone Coordinator for FOXy Hysteroscopy Workshop, Free Paper Committee in charge, AICT 2006. Apart from that, in terms of academic activities, Madam has already the author of 2 textbooks in gynecology, and she already participated in many national medical sessions. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation. And please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time once again in our platform Shield Connect. And over to you, Madam, for further proceedings. Thank you.
Thank you, Dr. Suman, Mr. Ganesh, and all the members of Shield who have given me this opportunity to share a case that I had recently. Good evening, ladies and gentlemen, and greetings to you from Sun Medical Center where I work. Is it a sunshine slideshow? Slideshow?
Yes, it's okay.
Is it on slideshow?
No, Madam. You can move it to slideshow.
Okay, yeah. So I had a case of HELLP with pancreatitis, and I learned a lot of things from my case. So I hope all my dear friends who have joined in to listen to this talk also interact with me, although it's only on the chat box, to teach me, and so that I can learn from you also, if any of you had cases like this. Well, in fact, what you think that HELLP won't happen to you. It's not like that. 1.83 patients admitted to the delivery developed HELLP syndrome, and this is coming from Kerala, Kolanjeri Hospital. And so Shirley Mathan, somebody has done this. So near home itself, people are 1 in 100, almost 2 in 100 are getting HELLP syndrome. So you have to learn about it. Dr. Weinstein in 1982, that's when I passed MBBS. So he discussed hemolysis with microangiopathic hemolytic anemia, elevated liver enzymes, and low platelet count. Now, what is this hemolysis with microangiopathic anemia? How do you diagnose it? You find schistocysts on the peripheral smear, so you know there is some evidence of hemolysis. That's how you diagnose this. So it can happen to you. It's not that uncommon. So you have to learn about it. There's no shortcut. So what will happen? A patient with the PIH can come to you with right upper quadrant pain, nausea, vomiting, epigastric pain, and you should think HELLP. No? So there you will have low platelet counts, SGOT, SGPT more than 70, and LDH more than 600. So there may be various classes. That's just academic, not in for practice. There can be many pitfalls because you can diagnose it as just esophagitis. Max to max, you will say it is cholecystitis. In corona seasons, you will think it is viral problems or even idiopathic thrombotic cycle. So you can just miss it. Like, persons will it's so common to have abdominal pain in pregnancy. It's so easily missed. But when a patient comes to you with BP and they have all this, you must think beyond that, So what else can you miss it? You suppose you do say it is HELLP. Then it may not be HELLP. It can be something else also. Something like hemolytic uremic syndrome, which will mimic it, or thrombocytopenic purpura. Why you have to diagnose this and not HELLP? Because in HELLP, you don't have to give plasma transfusion. Whereas if it is hemolytic uremic syndrome, which can come even after acute diarrhea or even plain genetically. So in these conditions, besides all your treatment of HELLP, you may have to give plasma transfuse, plasmapheresis, or sometimes even dialysis. So you have to think beyond HELP in those cases. Acute fatty liver can be real catastrophic, and you have to press the alarm button. Besides, you can have SLE, APLS, or even DIC, So all these conditions you will have from widespread thrombosis in the microvasculature and thrombocytopenia. So everywhere you will have the same picture, but you have to make the differentiation so that you can treat it differently. So if you don't treat it, what will happen? You can have pulmonary edema, DIC, liver hematoma. So you think it is esophagitis, gastritis, and you leave it alone, patient will suddenly collapse. So it's a serious thing. And what about acute pancreatitis? That can also affect 1 in 1,000 patients to 1 in 10,000 patients, depending on the studies. Like, some studies are quoting this. Imagine you have to study 10,000 deliveries to really know the incidence. But let me tell you this, when I talked to Dr. Lakshmi from Calicut Medical College, she says it's not that uncommon. She says, madam, it's not that uncommon. Whenever a patient comes with nausea, vomiting, and she's got epigastric pain, please go and do the serum amylase and lipase. It's not 1 in 1,000. Probably if all this Calicut Medical College people and all the medical college people started doing it, or even all of us start doing it, maybe we will report a higher incidence. So what is the hallmark? Upper abdominal pain, nausea, vomiting, anorexia, and raise serum amylase or lipase level more than 3 times. And you have to start doing it. Maybe we'll, know that the incidence is much higher. What about the fetal risks? If you don't treat it and don't take the baby out, it can go into premature labor and fetal death even, It's not to be ignored. Maternal risk is there. Mortality is 2%. Necrosis or abscess of the pancreas can happen. And what can happen cause this? Respiratory failure, shock, renal failure, DIC, or even GI bleeds. So these all can cause maternal mortality. Now, the treatment is giving fluids, nutrition, and the treatment of cause, pain control, and if necessary, ERCP or surgery or something else beyond that. But as far as we gynecologists are concerned, we have to give fluids, nutrition, refer the case. Now, what are the causes? When I say you treat the cause, gallstones can be there, PIH is there, acute fatty liver of pregnancy, even thiazide diuretics can cause it, hypertension, idiopathic alcohol abuse, and things like that. So all this can cause hyperparathyroidism or even genetic causes. So all this can cause a problem. So you have to know the cause also. So I had a patient who was a 31-year-old primi gravida who presented on 4/2/22. She had undergone embryo transfer on 1/7/21. Ultrasound on 22/1/22 showed diamniotic dichorionic twin gestation. And they were showing 31 weeks gestation, which means it was corresponding, So there was no IUGR. She just came saying her routine doctor was not available in the evening. She's got nausea, vomiting, and upper abdominal pain, which she ascribed to gas. The uterus was irritable, cervix was closed, and the fetal heart in both fetuses was present, on the table. There was epigastric tenderness, and she was acutely distressed, pain everywhere. She couldn't even stand. to take the height and weight, normal routine procedure done in the hospital. She can't stand on the weighing machine. BP was 150/96, and the patient was already on Nicardia, 10 milligram BD and Dufeston and Pantocid, everything was going on. So now what more can I do for this patient? She's already on everything. And so I thought there's some intestinal infection. Anyway, I said, pain, nausea, vomiting, hypertension, please do the LFT, please do the total count. And then what happened? I found that I also put her on a duodenal drip, Pantocid, Perinom, all the works. I even gave a Betnesol injection. But the pulse rose to 130. Sister said, madam, the pulse is rising. So then I had to stop the duodenal drip. And the results came that SGPT is raised, platelets are low, and CRP was 1.6. But it was just 50,000, So I said, and I already had another emergency going on there, and I was really upset. So I said, please call the physician. And I said, CRP is raised, to start around cefiperazone sulbactam. And maybe we'll do an LSES tomorrow because things are not looking good. We'll think about it, But physician said, you please look at anti-dengue and anti-leptospirosis because all these people are having platelets low. So we even thought in terms of that, By next day morning, physician also told me, please think in terms of HELLP. So yes, and next day morning, Dr. Rashmi from Medical College Thrissur called me for some other reason. I told Rashmi, I've got a patient like this. And she said, madam, do serum amylase and lipase also. That means what? Whenever they get HELLP or whenever they don't get HELLP, whether it is Thrissur or whether it is Calicut, they're always thinking of pancreatitis. And lo and behold, yes, it was pancreatitis. Serum amylase and lipase was 3 times higher. Blood sugar was 625 milligram per deciliter. And that was because of pancreatitis, because she was not GDM before. So it was emergency. We had to do an LSCS in the morning. And, the serum creatinine was 0.9, which had actually risen to 1.2 next day. So that means the renal failure was setting in. So what should I have got alarm with 0.9 serum creatinine? Yes, I should have. Because increased GFR in pregnancy can lead to a reduced serum creatinine in pregnancy, So if it is more than 0.8, actually it denotes kidney injury. So 0.9 itself is kidney injury in a pregnancy. So I should have got alarm there itself. But yes, serum lipase level has got a more sensitivity than serum amylase. And pancreatitis can mimic HELLP. PAH, HELLP, pancreatitis, all of them come together. And so you have to think of everything when it comes. So this is the lesson that I learned. When I put her for surgery, you can't give a spinal anesthesia because they have a bleeding problem and her APTT was prolonged. I called up Dr. Deepthi, who is another gynecologist in my hospital, and she said, madam, put in a drain. Yes, Deepthi, I thought it was because there is bleeding which will be, no, we don't look at it. But in fact, this patient also developed ascites and it was good. The drain was draining 200 ml, 100 ml on the second, third day. So it was a very good thing that I listened to Deepthi and put in a drain inside that abdomen. And by the time I finished the surgery and went down, the sister called me saying, madam, she is bleeding from the incision. So I put in a drain under the skin also. A Ryle's tube was put in under the skin. And I looked up in the references and they all are asking for a subfacial drain in HELLP. And pancreatic, whenever you are doing these things, when there is a bleeding problem, put in a drain inside the abdomen and a drain inside the skin incision. It was draining, yes, because there is a clotting problem. And actually, the indication for platelet transfusion is only platelet count less than 20,000. But the medical college people, they are giving 2 platelets. And when this thing was there, after surgery, I gave 4 platelets and 2 units of FFP. And the physician started the patient on an insulin pump. So I've already called the physician, I've called the nephrologist, I've called the gastroenterologist, and our intensive care person, the anesthetist is already on the patient. You need everyone's help in a case like this. That is there. But you have to be the primary person and realize the fibrinogen clotting activity was raised, APTT was raised, so she was having a clotting disorder. All these things you have to find out yourself. And you have to put in a CVP line. You don't wait for the physician to come and tell you. And by the time the end of the surgery, I told the anesthetist, put in a CVP line. You know why? PAH will cause tachycardia, and that is not enough to know that there is volume depletion. A pulse of this patient, in fact, had a pulse of 110, BP 120/80, and the CVP was only 2. Normally, you wouldn't bother, no, 110 pulse and BP 120/80, but the CVP was 2. That's because of the PIH. And they had given 2 pints of normal saline transfused very fast. Would you ever do that for a BP of 120/80? But the CVP helped us to find out that she was dehydrated. And that CVP was kept, and it will also show you when she is overhydrated. So CVP is very important in this case. And immediately I asked for acid-base balance. I said you put in an intra-arterial acid-base things. So, but they could only get it out from the vein, I think. But still, we could diagnose that the bicarbonate was low, pH was low, normal pregnancy is 7.5 with the patient's values. She was 7.2. She was ketoacidotic, and by the time the nephrologist came, he had the values in hand. He started IV soda bicarbonate, 25 ml, 8 hourly, So you as a primary person has to do the CVP, acid base and everything ready by the time the physicians come. And the anesthetist started Pentalin infusion. And I always give inguinal block for my patient and tramadol rectal pessary and IV paracetamol SOS. You can't give NSAIDs for these patients because they are having clotting disorders. But, by the night, the patient is still saying, after everything is over, she's still saying abdominal discomfort, and she requires 5 liters of oxygen, pulse is high, and BP is high. So what to do now? I said, rebound tenderness is still there. So I changed the antibiotic. You can't use a pistol to, kill big thieves. You need a machine gun. So I started meropenem 2 gram IV 8 hourly, and also IV metrogyl. Although theory says that when you are giving carbapenems, it will act against gram-positive, gram-negative, and anaerobic bacteria, and you don't need to give gentamicin or metrogyl. Gentamicin, anyway, this patient has got renal failure, you can't give. So meropenem is the best, and you don't have to give 1 gram TID is enough actually. But because this patient was looking so sick, I gave 2 gram hourly, which our pulmonologist had taught me for another case. The 2 gram TID is okay. And second post-op day, still she's getting a need of 4 liters of oxygen. And the CVP was being maintained by the nephrologist with 100 to 200 ml of fluid, So between 10 and 16, they were maintaining it. And the platelets were repeated next day. Again, it was 30,000. So again, I gave 6 units of platelets and 2 FFP. And the HP was normal, But the creatinine, I told you, was rising to 1.2. That means there is some renal problem. Amylase and lipase had reduced, and the calcium was low, and IV calcium gluconate was given. Now, by evening, the oxygen requirement is not improving. Still, the tenderness is there. It's better than yesterday, but not better from morning. So you have to understand all these things as a primary physician. And I rang up the physician, asked him, I want to start tigecycline. What is the dose? And he gave me the dose 100 milligram stat and 50 milligram 12th hourly. Although he said, madam, this is pancreatitis. It is not antibiotic related. It's not necessary to go on increasing antibiotic like that and all that. But I said, no, I want to start it. And Mucinex nebulization and Budicort nebulization was given after consultation with the physician because her oxygen requirement is increasing. So not decreasing. So I gave all this. And so what is tigecycline for all gynecologists here? Yes, it is a novel drug used both in complicated intra-abdominal infections and complicated skin infections. And it has a wide spectrum of activities. So when meropenem is still not working, I have to add some more drug. That's what I feel. And I don't know if I was right or it would have happened by itself, but by third day, the distension was persisting, but at least the patient is saying that the pain has decreased. She's still uncomfortable, so I'm still getting scared. So now I passed in a Ryle's tube after consulting another doctor from a medical college. But then the Ryle's tube did not show any secretions. But then I removed it because patient was uncomfortable. But by evening, God's grace, she opened the bowels. And the oxygen requirement by now was 2 liters per minute. And so patient is not able to stand up. So here By third day, if she cannot be mobilized, you have to call in a physiotherapist and start physiotherapy. Otherwise, she will have a problem later on. So physiotherapy was started. By fourth day, then the GI physician was saying, you get an MRI, but then they said the MRI plate, they can't keep on the abdomen. It's very heavy. So we got a CT scan, and it showed collapsed lung. The abdomen was okay. Collapsed lung was there in spite of all these inhalations, all these antibiotic. Now what more to do? So I discussed with the physician and he said, we will start a spirometry so that the lung will improve. So we started spirometry. And another thing was, the albumin levels continued to remain low. First, I started giving FFP because it is cheaper. Then I gave albumin. Still, albumin level did not come up. And finally, over the days, it did come up. Come up, So it's not easy. Why is the GI person saying you get a CT scan or MRI scan? And why the nephrologist said you get an ultrasound done? You have to find the cause of the pancreatitis. You have to know whether there is a gallstone, whether there is something else. So that's why they need, and they need to know about the ascites. Of course, there is a drain in the abdomen, so the ascites will go. But that's why you need a scan there, So at least a CT scan should be there. So it is an accurate technique of detecting acute abdominal pain. We know it is pancreatitis, but even then the cause can be detected, and she had undergone a CT scan. Now, when the CT scan was being done, the previous day, the technician gave me a slightly different report saying there is a mass in abdomen, and I was getting so scared, and what to do now next day morning, mass and the hematoma, how to do, all these things were going on in my mind and I couldn't sleep. And the CVP monitoring was going on 4th hourly. And at 2 o'clock after a game of chess, I rang up the ward and asked, what is the CVP? And she said, it's 21. I said, if it is 21, you have to do something. And they had already given SOS Lasix 10 milligram earlier in the day, after consultation. So now again at 2 o'clock in the night, I said, come on, give another Lasix. So this thing, you have to remember that even if the CVP is monitored 4th hourly, please give instruction to the staff nurse that if it is rising, you please inform some doctor. Because there are 3-4 doctors handling it. They also probably don't give it, inform anybody. So you have to give Lasix or something. Otherwise, they'll go into pulmonary edema. So you have to be on the patient, 24/7. You have to monitor how. You cannot just give it off to the physician because you are the primary physician of the patient. They will help you. One thing I learned about serum calcium in this patient, she was actually having 6.4 serum calcium earlier. And it came down to 6.3. They were giving IV calcium gluconate. And I was getting alarmed, like, sodium and potassium, you give sodium, potassium, it will improve. But calcium, they are not allowing you to give like that. Why? Because if you give too much of calcium, it will enter the pancreatic cells and it will cause more damage. So there is a controversy about giving calcium in acute pancreatitis. So our nephrologist rightly switched over to oral calcium. And if at all he said, don't give calcium, give just a little bit, but not as intensively as you would give in other patients. In pancreatitis, you cannot give calcium left and right without getting worried about it. Just low calcium is not enough indication. And by 6th day, it had risen to 8.3. So the literature is saying you cannot give it in acute pancreatitis because it's a controversial topic. And now the gastroenterologist, we were fortunate that he had an armamentarium of things that we would never think of, like a lyotide infusion. Cilio is some extract from Cilibium. And Enzar is a pancreatic enzyme supplement and some tabloids, And our physician gave Febujet to reduce the uric acids, which was increased in this patient. And ursodeoxycholic acid, which we all give for our ITP patients, when they come with pruritus in pregnancy. We're all familiar with that. So all these things were given by my physician friends, and all that helped in improving the patient, which we would never think of as a gynecologist. So it was good to have all these people around there. And she was shifted out of ICU on 5th post-op day and discharged 8 days later. The delay was mostly because of the neonatal care. The baby was taking time to come out of the thing. And just to discuss about this, causes of pancreatitis. Biliary pancreatitis with the presence of gallstones is the usual cause, or you can have stasis. Even severe triglyceridemia can cause acute pancreatitis. That is to the tune of 1,000 milligram. That is why our physician, he always said, go and get the lipid profile. And I was saying, the patient is so sick, you are worried about her cholesterol. I was thinking in my mind, but yes, hypertriglyceridemia is a predisposing factor for acute pancreatitis. Fortunately, our patient had a raised triglycerides. It was only 173. That was not the cause in this case, at least. Now you are all wondering what happened to the babies. First baby was 2 kg. He cried after resuscitation. I said, let me wait for a few minutes. That baby is resuscitated before I take the second baby out. But the second baby was stillborn and had skin peeling on the scrotum and the leg. Signs of maceration. But let me tell you, both the fetal hearts were heard simultaneously with the monitor with 2 probes. Maybe one of them was picking up the maternal pulse, I don't know. But this is what happened. And the baby had hypoglycemia and later infection. They did an HELLP. They had to give meropenem. But the baby came out of it very well. But it did take time. Yeah. So, in short, mild acute pancreatitis is associated with minimal organ dysfunction and uneventful recovery. So you have to give fluids and normalize the physical signs and lab values. It can go into necrosis, abscess, or pseudocyst, and it can go into organ failure. What is organ failure? Shock, BP lower than 90, respiratory insufficiency where the oxygen level is less than 60, renal failure, GI bleeding. Our patient had GI bleeding. When she passed through, she said it was dark in color. It could be because of the iron ingestion, or it could be because of GI bleed, whatever it is. She did have respiratory insufficiency because without oxygen, the oxygen level was coming down, but not to the tune of 60, I think. But yes, there was mild thing. So maybe we can classify this as mild acute pancreatitis, which was mimicking HELLP. That's what I would put it like that in this patient. So that's how it was. And the calcium level also can be very low. Like this patient can be lower than 1.87. That will denote severe metabolic disturbance. But in this case, it was not that low. Pancreatitis usually occurs in the second or third trimesters. Because of the large uterus, the gallbladder motility is decreased, and so there will be cholestasis, and there can be ischemic injury to the pancreas. And that is the pathogenesis of acute pancreatitis usually, and it can lead to multiple organ failure. Estrogen-related increase in triglycerides can also produce it. Biliary pancreatitis is the main type, and there can be a hypertriglyceridemia to a 4-fold increase in pregnancy itself. So every time you see triglycerides increase, don't think it's going to go into pancreatitis, because hyperlipidemia is pregnancy is an entity called physiological hyperlipidemia, triglyceridemia. Only in very high doses, it can, high levels, it can lead to acute pancreatitis. Every time it rises up, you don't have to press the panic button. No. And as I told you, bowel rest, don't let her eat, intravenous hydration, and you monitor everything correctly, call the physician, they'll do it. But you have to be at the patient's bedside every time and find out what is wrong. You cannot leave it to the sisters. And as the severe maternal morbidity is an indicator for termination of pregnancy, whenever you are diagnosed in pancreatitis, you have to terminate the pregnancy. And C-section is the preferred mode for the prevention of other complications, such as aspiration. So with that, I have completed my presentation, and I hope you have got some practice points in it. I thank you all for your patience.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time to check whether it's a question is there.
Okay.
one question is there, that is, does only preeclampsia only cause this HELLP, or is there any other clinical conditions that to be thoroughly checked during pregnancy that can lead to this HELP?
HELP, I told you, HELP can be caused by preeclampsia, and also when you HUS, DD, I told you. HELP is mainly caused by preeclampsia. Even pancreatitis can lead to HELP. Antiphospholipid antibody syndrome, all these things can lead to HELP. In this patient, it was mainly pancreatitis related HELP. That is what I would say.
Yes.
And
yes.
DIC, SLE, all this can lead to HELP.
Sure. Thank you very much.
So no other questions?
And madam, another just one question is there. So, diagnosed after 34 weeks of pregnancy, this HELP syndrome. So, what will be the further consequences? It will be management or plan to deliver for the baby if the patient.
I think I would deliver the baby. 34 weeks is enough. I mean, the baby can be looked after in an NICU very easily after 34 weeks. HELP is not to be played around with. 34 weeks is good enough to deliver the baby. Why
so it
not?
is your recommendation to deliver the baby if the clinical vitals parameters are normal in case of this HELP syndrome?
In my patient, I had in fact given Maxel before delivery, and maybe you can just give Maxel for neuroprotection, give betnesol and deliver the baby. You can give that much of delay for delivering the baby. Give Maxel and betnesol to prevent pulmonary insufficiency and neuroprotection. These two things you can do. 34 weeks, I don't think even that is necessary because it's good enough.
Okay. Thank you, madam. And I could not find any other question. So thank you very much once again for your valuable time and for discussing such an important and nice topic. And in future also, ma'am, we will look forward to some valuable session with you. Thank you very much, madam.
Thank you, Dr. Thank you, Ganesh.
Madam Ganesh here. Thank you, madam.
Thank you, Ganesh.
Yeah, and Suman, one more thing is we have continued this as a series. So this critical care in OBGYN is very unique because you remember that we have not done such events. So madam will be part of this series. So thanks a lot, madam. Thanks a lot.
Thank you, Ganesh.
Thank you very much, madam.
Thank you so much. So can I leave now? There's nothing. Okay.